right, so welcome everybody to our journal club tonight. This is a setup. We've actually set up modules. This is the second portion of the hip module. I know there was a webinar recently and there will be a fireside coming up. This is the journal club portion of that. After this module, there will be a distal radius module, which will follow the same format. But tonight we're going to talk about geriatric acetabular fractures, fixed versus traumaplasty. We have a fantastic panel of experts here joining us to discuss. We have Mike Leslie, who's here along with me at Yale University. We have Mike Weaver, who's up in the Boston program from Brigham Women's, and Aaron Johnson down at Shock Trauma University of Maryland. All of whom are trauma trained, also do a lot of hip arthroplasty and have learned how to combine those skills to properly and most effectively take care of patients who may benefit from it. I'm Matt Riedel. I'm an assistant professor here at Yale University, the chair of the geriatric hip fracture program at our institution, and I'm going to help chair as we run through. I'd just like to remind everyone, if questions come up over the course of the presentations, just put them into the Q&A section. I'll help moderate those and try to get those questions answered and peppered in as we work our way through. But we'll try to get to all the questions as we move along here tonight. So to start out, we're just going to show a few cases, and they're cases that are made to make you think, right? You see the fracture patterns, but think about patient factors, maybe the patient's age, their functional level, if they had any antecedent hip pain, if they could tolerate protected weight bearing or limited weight bearing, or maybe they need to be able to weight bear to get around. So just some thoughts on these different fracture patterns and different patient characteristics. A few more images of some of these injuries, and you can see in that CT scan, maybe they're associated with a really complex femoral neck fracture and antecedent hip arthritis. What are we doing for these patients, right? Are we best treating them with fixing, or maybe they deserve an arthroplasty right from the get-go? Maybe they deserve a delayed arthroplasty. So these are some of the thoughts that we're going to discuss amongst the panelists and try to answer questions as they come along as we move through. Again, I'm going to help moderate and chair the course. Here are your faculty presenters who I've already introduced. Our disclosures, none of which are relevant to this talk. This is eligible for CME credit, so to receive that credit, a link will be sent to you after the conclusion of the series, and you'll fill out a questionnaire. You'll be able to claim your CMEs. A little statement on AO North America, our content validation. And finally, Zoom etiquette. We ask that all microphones stay muted, cameras are turned off. Any questions that come through, send them into the Q&A box and I'll field those. And we'll go along here as we get started. Our objectives tonight are that we're going to review some classic and current articles as to why certain studies were conducted and really explain how this literature has advanced or changed our practice. We're going to look for some best practices based on not only on scientific evidence, but the clinical practice of our experts as they go through. And then finally, we'll have a live discussion, maybe changing some practice defining concepts or principles that you may have come to learn. A quick overview of the plan for timing. So we're going to spend 5 minutes doing as we are now. We'll run through a few cases over the next 5 minutes, and then we'll work through each of 5 articles that have associated cases attached to them, and we'll see how those cases relate to the articles and what the articles had shown. Some thoughts as we work through each of these cases and articles, right? What's that article about? Is it really important question, and why, or maybe why not? How did they design their study, and what were their methods? Were there any obvious limitations? I can promise you there are some limitations in a study such as this, given it's such a limited practice. Was there a clear hypothesis? What were the key results? Did they find anything that really was counterintuitive to what they expected? Did they prove their hypothesis, or did they disprove their hypothesis? Are there specific strengths or weaknesses we want to discuss? And would the results of the study or the case associated with it maybe change your practice or change how you view these injuries moving forward? We'll work our way here into the first case. I'm going to hand control back over to Dr. Leslie, who is going to go through this first case.
Great. Thank you very, very much, Dr. Riedel. I'm not sure I have control yet here, but so the first paper we're going to discuss tonight is a paper discussing the incidence of acute total hip arthroplasty for primary and adjunctive treatments of acetabular fractures in older and middle-aged adults. This is a current paper. The good news here, there's not a lot of classic papers related to this topic, right? We honestly don't even have very many classic papers regarding outcomes of acetabulum fractures in this particular age group. So, we're going to work off of what we have, and we're going to discuss some of the current papers that are kind of discussing what we're starting to do as a community of surgeons. So this paper was put up by Dr. Patterson from California, and really looking at the overall incidence of what's happening with these particular procedures. So basically what they did in this paper was they went about it that the hypothesis was that the use of total hip or total hip with open reduction internal fixation was rising. And what they used to do this was they looked at the National Inpatient Sample Database between 2010 and 2020. And they were looking at the rise during that period of time, if there was one. So what they found was that they had 4,569 patients who had surgical treatment of acetabulum fractures from the National Inpatient Sample Database. So now this only represents, as we know, 20% of the inpatient admissions across the across the country. But they did subdivide these. They subdivided them into ORAF, total hip, or ORAF plus total hip. And then they went ahead and they looked at age. And I thought this was kind of interesting that how they looked at this, because they looked at between 45 and 64 years old, and then 65 years old and older. I think for the most part, when we're talking about ORAF plus total hip, or even total hip utilized for acetabulum fractures, I know in my practice, that really is almost exclusively over the age of 65. Really, I try to reserve that. But then when we started to dig into this literature a little bit, and you'll see this through some of the upcoming papers, there's starting to be a trend towards doing it even in this younger age group. So I thought this was a pretty interesting kind of subdivision that they did. And the way that they went about the data here was very straightforward. They just did a linear regression, purely really looking at incidence of these three procedures and the changes over the course of 2010 to 2020.
Excuse
They
me,
looked at
I'm
some
sorry
other
to
things.
interrupt. Are you
Oh, I'm sorry.
advancing the slides? Because we're not seeing them advance if you are, and you're in,
Nope.
could you go full show? Yeah, you're in slides order still.
Oh, I
Thank you.
apologize.
Perfect.
So,
There. Great. Thank you.
um, so basically, and I'm not advancing slides, so we're just talking on this. So, so when they looked at this, knowing that we're only representing 20% of the total inpatient data across the country, they found that there was a significant rise in the use of total hip and ORF plus total hip, and that difference was a rise in total hips over the age of 65, up 16.5%, and for ORF plus total hip, over 5% rise. Um, so that was really a very telling thing towards what people are getting more comfortable with. And for better or for worse, and we're going to talk about that in upcoming papers when we talk about readmission and complications related to this. Are there any? How are the patients actually doing? So, and that does represent a 21% decrease in ORAF in patients over the age of 65. So very kind of telling paper towards what people are actually doing in our communities. Some of the other simple things that they looked at were insurance status. So obviously this is going up in Medicare patients over the age of 65, but kind of to be expected. I thought some of the other things that were interesting in here were that they found that there is an increase in female over male, which I think also makes sense considering the fact that there's osteoporotic patients and osteoporosis is much higher incidence in women than men. And they also found that it wasn't just teaching institutions where this was being done more commonly. So this is also being done in community settings and even in urban settings that were unrelated to teaching. So it's kind of an interesting look at all this. And there are obviously some limitations. The first one we discussed a little bit. We discussed the limitation of this only representing 20% of the total population of these particular codes. It is also confounded by the fact that there's a classification and reporting bias whenever we're looking at any database study. And we have to keep in mind that in 2015, we switched from ICD-9 to ICD-10. So that really could have changed how these were reported over the course of that time period. But overall, I think a good representation of the fact that this procedure that utilizing total hips is rising, and utilizing ORAF plus total hip is rising for whatever reason. So, so that was the basis of this study. And I just figured we'd talk a little bit about what we do know about acetabular ORAF. So, acetabular ORAF, right? Basically, the one paper that we have to go to that really explained how we could potentially do with a lot of these patients. And the gold standard of outcomes is Dr. Mata's paper from 1996. And when we really look at this, it's 262 operative fractures achieving only 185 anatomic reductions. 29% of those suboptimal reductions correlated to the complexity of the fracture, the increased age of the patient, and the time to the operating room. All things that we really need to consider for these patients. Now, when you had a great reduction, 40% excellent results, 36% good results, but 8% of those still went on to a total hip or a fusion. So, it's really all about getting to that anatomic reduction, and can we get there? So the question that I ask, and I would ask our panelists here, so how do we think these particular patients would do with open reduction internal fixation? And would these be patients that we would consider a total hip in, or ORF plus a total hip? Aaron, if you have a thought on either one of these patients, just one X-ray each.
I mean, I think both of these patients show, some of those classic signs that Dr. Mata talks about, that where the patients would, sort of have risk factors for having problems after ORAF. There's different challenges to each of these, but I think both of these patients would be considered for ORF plus total hip at our institution.
But would there be any differences, anything in particular that might lead you towards or away from that for individual patients?
I
In
think
your current practice?
we sort of have a very similar approach to these. We start by, I think age would be the biggest, right? I mean, if the patient on the left is a 40-year-old, then that may sway me towards taking a swing and trying to put this back together. I doubt that they are. But the dome impaction in both of these would, I think, push us towards having the conversation of putting a total hip in these acutely.
And that leads us to our first question from the attendees. What age really sways you to first consider a total hip? They asked, in older than 45 patients, is a total hip first considered or not? What's kind of the age limit you guys start to really think about that?
Well, I mean, I would flip it around, and how do you treat a femoral neck fracture? Because these are hip joint injuries, and if you have a displaced femoral neck fracture in a relatively healthy, physiologically young patient, then you try to fix it and get it to heal. And if you have that same fracture in a more geriatric patient where the chance of failure may only be 40 or 50%, we still go with the hip replacement. And I think the same answer is true here. I think some of the papers that we're about to discuss are really interesting because they really do talk about doing this in a younger age population, but it would be a very unusual patient in my hands that's under the age of 60 that's getting a total hip. Certainly if there's someone in their 50s with really bad features, maybe, but the vast majority of these, at least here, are done in people that are over 60. Mike and Aaron, what do you guys do?
I think it's very similar. There's a paper that talks about the statistical likelihood of, if you get a total hip, what age when you get that total hip, you are sort of predicts whether or not you need another surgery. And there's, I think in that 58 to 60-year-old range, if you're that age and you get a total hip, you're less likely to need another surgery. That obviously isn't in this patient population, but I think we tend to use that cutoff as our guide. I think the 60-year-old patient is more likely to have the conversation about Geriatric, are we doing fix and replace acutely versus the 45-year-old patient?
Yeah, I think I'm right along the same lines. And what we see for these particular patients, so it turns out the patient on the left-hand side of the screen is 44 years old, fell down the stairs at her home, and the patient on the right side of the screen is 88 years old, lives in an assisted living facility. So kind of two completely different patients who, got a nice anatomic reduction on the left. Oh, I'm sorry, 49 she was. So nice anatomic reduction on the left. So we felt comfortable with that for bone quality. Not as anatomic reduction on the right-hand side of the screen. Also had an exploratory laparotomy, couldn't tolerate a lot of surgery. Different patients, different problems, and I think that's probably the thing that we're going to see come about here as far as how do we treat these patients. So great discussion there. So again, I think we see a lot more of this being done, but maybe we haven't actually delineated who these patients should be. I think we could probably move on to the next paper. Dr. Johnson, I will hand it over to you here.
All right. So the next paper up for discussion is this paper here, higher rates of readmission after acute total hip versus ORIF for elderly acetabular fractures. This is a paper out of UCLA. It's a similar study design to the previous paper. And so they are using two databases to ask several questions. So the first question, or the first database they use, is the same database as the last study, which is the NIS database. And the second is the National Readmissions database. They asked two predominant questions. The first was they wanted to look at trends in surgeons choosing total hip over ORIF for elderly acetabular fractures. And then they wanted to look at the differences in short-term complications, costs, and readmission rates of the total hip patients relative to the ORIF patients. And, I think it's sort of an important question because once you get into putting arthroplasty in these folks, this is, I don't know about at your institutions, but at our institution, the total hip, primary total hip patients are tracked very differently than the trauma patients are. And I think nationally, there's a lot of metrics around length of stay and expected complication rates around primary total hips. And to the uninitiated middle manager who may be collecting your data at your hospital, they may not on first glance be able to differentiate a primary total hip in the trauma patient that's had an XLAP and has going to be in the hospital for 30 days, regardless of whether you're putting a primary total hip in them versus your elective, outpatient primary total hips that are going home 2 hours after surgery. So their, methodology is very similar in terms of the database with all of the problems that come along with that. The outcomes that they used, they looked at the 30, 90, and 100-day intervals for readmissions, comparing between patients who had acute total hip versus the ORIF. They included patients who were 60 years of age or older. And they also did some matching between the two groups, whether the patients received total hip or ORIF, and it was not exactly clear how they matched the patients, but they did match them one-to-one to get some of that data. The first result, which was sort of kind of a red flag for me when I was reading this, is that they asked almost the same question with the same database over the same time period as the previous paper, and they came to a different conclusion, which was that there's no difference over time with the incidence of total hip. And, now the question is which paper is right. And I think that's just sort of a nice illustration of the point that these databases, they're good for what they are, but take the data that you get out of them with a grain of salt, because, you can't get more similar questions with a similar patient population with a similar outcome, and it's two completely divergent conclusions. So that was their first question. They did also conclude that total hips had a shorter length of stay. They concluded there was no real difference between cost between total hips and ORIF, and no difference in the disposition rate between the two groups. They noted similar trends in the total hip group as the last patient in terms of higher incidence in the females, the Medicare patients, and the non-teaching hospitals. And I don't really know what to make of that. And I don't know whether that's that there's a decreased availability of trauma surgeons that are able to fix them, and maybe there's some arthroplasty surgeons that are willing to take them on, or if there's something else. But I thought that was sort of an interesting trend that was picked up. In the next part then, where they looked at readmissions, I don't totally understand how they matched, but they did match 1,300 patients that had total hips to 1,300 patients that had ORIF, and this is, maybe I'm putting the cart in front of the horse in terms of being critical of matching, but it's, we don't know fracture characteristics, we don't know surgeon characteristics. But I think there's a lot of variability that goes into this to really make me question, are we comparing apples to apples for this? But their conclusions from it was that at the 30-day outcome, total hips, and really at all of the outcomes, total hips had higher readmission rates. Seems to largely be driven by dislocation at every time point. And then as you got further out towards the 180-day time point, the infection risk started creeping up in the total hip group. And I think that trend sort of makes sense. I think the further, at least in terms of the further out you get, the more likely you are to see the infections. We're not, at least for us, we don't tend to see the infections in the early 30-day period, but I think probably by 6 months to 9 months, you're probably seeing 90% of them, which is similar to what they're showing. So their conclusions then also, there were some questions because and I think a lot of the papers hint around this, but they concluded that low energy elderly acetabular fractures will become increasingly common, and that this study defined a potential trade-off between total hips and RFs, which I agree with. But I don't know that this is necessarily a low energy, I don't know that this study is a study of low energy patients, right? You can't really piece that out of the data. And be curious to get your guys' thoughts about, the low energy geriatric acetabulum, the 80-year-old osteoporotic patient that has terrible bone quality versus maybe the 60-year-old who's in a motorcycle accident that has pretty good bone quality, but some dome impaction and a femoral head injury. To me, at least when we're taking care of these, those are two very different patient populations that sort of get lumped into this. So I think there's, as with all the database studies, there's useful information. And I think it especially is in these sort of outcomes reportings, and it's how you're dealing with these outcomes with the hospital. Do you guys have, similar sort of, how do you guys deal with this primary total hip population and, sort of the inherent higher complication rate that comes with it when you're dealing with hospital administrators and readmission risks and, keeping the big picture in focus with them?
Yeah, I think you bring up a really good point there. And I think it extends beyond just this indication. I think for those trauma surgeons that do arthroplasty, often the cases that we're doing are a little bit different than our colleagues that are doing outpatient surgery. Like our patients tend to be sicker. They're more likely to have comorbidities like diabetes and smokers. They're more likely to have fractures, which we know, like even a femoral neck fracture is a much higher dislocation risk with an arthroplasty than not. And I think these are definitely that. And I think educating your hospital administrators and your colleagues in the arthroplasty division are really important. You guys need to be a team, because if you look at your readmission rate or your complication rate, it may be a lot higher if you're tackling cases like this. And that's just part of the game, unfortunately.
Yeah, I totally agree. It's very difficult to parse out these particular patients. And I think, I would almost wish there was a modifier that would effectively be captured by the coders, because I honestly don't think the coders are catching any of what we're telling them. So I think it's very challenging. And, when we really go back and try to look patient by patient, when it gets time for reporting, it's almost impossible. So I think it's something to definitely keep in mind, and it might explain a little bit why, these cases are being done by the people that they are. But it is very interesting. I thought it was tremendous how the data was the same data set in the same period of time with totally different, it really does highlight the difficulties of reporting here.
Well, and I think you guys brought up a great point with patient selection. I mean, Aaron brought up the 67-year-old who crashes a motorcycle, who's considered a geriatric acetabular fracture, is also compared to the 96-year-old who fell over in their kitchen. And I think giving the 96-year-old a contained hip without a total hip arthroplasty and reduced risk of dislocation, they'll do very well, right? They're going to get around on a walker and mumble around their house. But the 68-year-old or 67-year-old who wants to get back on their motorcycle has a very different functional outcome expectation. So I think that there's an upper limit, just like we were discussing a lower limit in these considerations as well.
I think the other thing to keep in mind is that, like, you know, your 90-day complication rate is not really that important for these. Like, it's nice to know, but the game here is really the equation of post-traumatic arthritis. And if you fix these, are you really changing the trajectory of this patient? So it's really the 2-year or 5-year follow-up that really matters. Because if you have a 30% or 40% of the patients that are treated with an ORIF are going to go on to a total hip at 5 years, then maybe that would be something to sway you. And that doesn't get picked up in these short-term outcome studies. So it's important to know, so you can say, oh yeah, we expect a higher complication rate, but just know that that's not what's really driving the discussion of should we be doing an acute total hip.
Yeah, I totally agree. You know, it's less this 30-day or 90 or 180-day complication rate, and it's more how many of these geriatric patients who have multiple medical comorbidities can we prevent them from needing a future surgery down the line, right? And it's, you know, you take maybe some of the early complications with that if you can prevent 40% that need to get converted to a total hip later on.
Yeah,
All
I
right,
think this,
so-
go ahead.
Go ahead.
No, I was just gonna completely agree but one thing I always find myself thinking about are the patients who, you know, when they have their fracture, they are acutely ill, right? They're acutely inflamed and they cannot tolerate big, long surgeries sometimes. And, you know, I remember Dr. Helfet saying at a meeting once, get there quick and know what you're doing and get through it. And if you're spending more than 3 hours, I think he wrote this in a paper once, if you're spending more than 3 hours fixing a geriatric acetabulum, you probably shouldn't be fixing a geriatric acetabulum. You know, and I think it reflects the fact that these patients maybe just can't tolerate all this surgery. And that's something I always battle with as far as, you know, you get yourself through the ORF part quickly in order to get to the total hip, and then they can't tolerate that same day either. So it just makes, I think there's so many unanswered questions here. I think this case in particular highlights it. So go ahead, Aaron.
Yeah. So sort of dovetails nicely with this. So 68-year-old, high energy, polytrauma. You know, these people come in, they tend to have head and chest injuries. They probably have a chest tube in, and you know, there's some comminution to the posterior wall. There's some column stuff going on, you know. So this, you know, do you think this patient is best served with a total hip, or are you guys fixing this?
Well, I mean, I think we've seen that, you know, we've described in the literature, right? A posterior wall more than 4 pieces is going to get arthritic, right?
Yep.
I mean, that's pretty clear in the literature. So why not consider a total hip for this guy?
And I think to all of your points, you know, I think it depends on how sick this patient is, right? If you can largely get the joint back together and get the patient out of the OR, that may be a shorter surgery than trying to put his column back together, get containment of the wall, and then do a total hip that isn't a chip shot.
And I love that we have these 3 panelists here. A question that came up and something I was actually going to bring up too. I love that we have the 3 of you talking about it, because we talk about the 40% risk of this going on to arthritis. How many of us have arthroplasty colleagues that really want to deal with these patients, right? They don't want to be doing this. So I was going to bring up, I love that I have Mike and you guys are at your institutions to be the person to man the ship and take these things on. But who should be doing these? Should it be a trauma and arthroplasty trained person, or should it be trauma trained people? That said, do we need to be doing a certain number of total joints to keep up with our competency? Or is it something where maybe we have a high risk arthroplasty surgeon willing to help us? You know, how do we spread this out further than the 3 institutions represented?
Yeah, I think there was a paper a couple years ago that came out that said if you're not putting 20 cups in per year, you're probably not doing enough cups. So, and that was sort of directed at, I think, the trauma surgeons that are putting hip replacements in. I'm curious to get the two of you guys' thoughts on this also, but it's from a trauma side, you need to be putting enough sockets in a year to be able to sort of competently and fluently move through that part. But on the arthroplasty side, if all you're doing is primary total hips, I don't know that really gives you the skill set to be able to take care of this patient either, right? This is very different than your routine primary total hip.
I totally agree. I think it's challenging, and to me, I always think about it as you need 20 different things in your tool bag here to deal with this particular patient, particularly if you're going to do it acutely. And even if you do it subacutely, you need 20 different things, and you have to be using those things all the time. And whether that's technology, or that is a different type of cup fixation method, or that is just an exposure difference, I think all those things make big differences for the patient and getting them efficiently through the operating room with a successful result. What are your thoughts, Mike?
Yeah, I think there are a couple different strategies, right? I think you're seeing one flavor here, because I think the three of us do both sides of this surgery, the fracture part and the replacement part, and I think that's a very reasonable path. I mean, I personally enjoy having a little bit of an arthroplasty practice. I certainly think you do need to have a volume of conversion and primary hips and a facility with the putting in sockets if you're going to do this. And that means not just doing them for fracture, you need more than that. But I have a lot of friends and partners across the country that do these cases with a partner. And I think that's also a very reasonable thing, particularly if you're a trauma surgeon and you like acetabular fracture surgery, and you want to dip your toes into this and kind of explore it, then doing these cases with a co-surgeon is a very reasonable strategy. And there are a lot of people that do these as a two-surgeon case, where the trauma surgeon does the fixing, and then the arthroplasty helps them a little with the exposure, and then they flip-flop, and the trauma person's kind of holding retractors. But I think either way, you either own it all and you have this as part of your practice, or bring in a colleague and do it together.
And just one more question from the group. What about ignoring let's say it's a posterior wall. What about ignoring the posterior wall altogether and using a revision type cup? I know I've talked to Mike Leslie about this putting in a primary is obviously much more beneficial, especially if the patient isn't physiologically very old. But what are your guys' thoughts on that?
So I put a multi-hole cup in everybody that I'm doing an acute total hip for Geri tabs. I'm trying to use the cup as a plate as often as I can, getting the screws above and below. The question in this one in particular, in terms of ignoring the posterior wall, I can say, having done that once, it ended in sadness, and I didn't do it again. And I think it gets at, there's probably some element of how big is the wall, how much host bone contact do you have, how much intrinsic stability do you have in the cup, and I don't know that we have the answer to that. And that's sort of one of my spectacular failures of Geri tabs early on, was trying to do just that. And then after that, I started just not necessarily piecing every piece of the wall back together, but at least getting a strap plate over it and getting the big chunks back down, so I have the bone stock there to sort of contain the hip. Now, I think if you're putting the hip in from the front, that's a different story. Or any of you guys doing a DA sort of approach for these comminuted posterior walls, and just putting a socket in from the front and ignoring that posterior wall?
I see you shaking your head, Mike.
Not for a posterior wall.
Yeah.
DA hip, maybe if you're doing a stoppa and fixing it, and then a DA hip. But for me, if there's a posterior wall, I'm fixing it. Like you, the only cup I've had pull out was that situation. And that gets to an interesting problem we have with these papers that we're getting into, is we're talking a lot about the outcomes of this surgery, but we're not talking a lot about how to do the surgery. And one of the big problems is, if you read, Juday's book, there aren't even 10 types of acetabular fractures. There's more than that, right? And so this is a very heterogeneous group of patients with a very heterogeneous group of fractures that need to be fixed in a very different way. And so not every one of these is a cookie cutter approach. And, I mean, I was always taught you need two opposing surfaces to really grab that cup. And if you've got a significant wall fracture, you just don't have that posterior grip. And so you need to restore that in some way with the plate.
Yeah,
Mike, do
I
you
couldn't
do
agree
them
more.
only from the front, or is there a?
No, and my practice is largely an anterior based practice for a lot of stuff, but anything posterior column, posterior wall, I'm going to go in the back and do the hip from the back also. And anything, and I'm really thinking about instability. So if all that energy went out through the back, and that's where my instability is, and that's where the soft tissue injury is, that's where I want to create a buttress, and that's where I want to do my work towards avoiding that instability. And same flip flop from the front. I'm thinking about that instability from the front, and how can I contain that hip? I think is exactly what we're all saying. All right, great. Why don't we
Right,
keep
yeah,
moving here to the next paper?
Moving on to the next
Forward,
paper.
yep.
So I think a lot of that discussion sort of blends nicely in with this paper. So this paper is in Journal Arthroplasty. It is out of Oregon, and the title of it is The Risk of Revision and Complications After Total Hip Arthroplasty for Acute Acetabular Fractures. And so this is another database study. They used a different database, but their primary aim was to determine the risk of revision after total hip, the treatment of acute acetabular fracture, through what they called a robust National Administrative Claims Database. And the second aim was to evaluate the risk of major surgical and medical complications, including the association with demographic and comorbidity characteristics. All right. So they used Pearl Diver over a 5-year period, and they defined, they searched for patients that had a diagnosis of an acetabular fracture but were treated with total hip. And they defined it as acute, delayed, or late. And the acute total hips were performed within 3 weeks of injury. The delayed total hips were between 3 weeks and 3 months. And then the late total hips were done 3 months after that. So I'd be curious to circle back and get everybody's thoughts on sort of that definition and up to the 3-week time mark. And if any of you guys are waiting 3 weeks to do your acute total hips. And then they sort of pretty typically define your complications as surgical complications, medical complications, and then look at all-cause revision total hip surgery using typical ICD-10 codes. So they found 955 patients that they said had an acute total hip with the first 3 weeks, and they broke it down into 240 that had ORIF plus total hip, and then another 715 that had total hip only. That's another sort of very interesting statistic because, as you know, we do a lot of Geriatric acute fix and replace. I do not do a lot of Geriatric total hip only. So it sort of makes me question what are the patients that we're looking at in this, and why is that statistics so skewed to a majority of them being predominantly total hips without ORIF. So their results were that the surgical complications was about the 26%, with dislocation being the most common, followed by what they called mechanical complication at 14% and infection behind that. And I think, that seems a reasonable assessment of this risk, but I think, there were some other statistics that I didn't find very helpful. They concluded that obesity was a risk factor for complication in all of the patients. Then they found their all-cause revision rate was 18%. And I think that's sort of comparable with many of the other reports. But, this, I think, gets at some of the points that we were talking about earlier in terms of who should be doing these. And I think this sort of feels like a very arthroplasty look at this. And there are, 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 when I talk to my arthroplasty only colleagues, their sense of treating these patients is that the risk of putting a hip replacement in these patients is unacceptably high. And I think that sort of comes out in some of the conclusions of this. And I don't know that this paper changes my practice any, but it really makes me ask some questions. And the questions that I ask after reading this paper is, who should we really be comparing this patient population to? Right? Should we be comparing Geritab total hips to primary total hips? Should we be comparing acute ORIF plus total hip to Geritabs that only got a total hip? Should we be comparing them to Geritabs that only got ORIF? Or should we be comparing them to the patients who were Geritab fractures, got ORIF, and then got converted to total hip? Right. And I think so, even within this very small subset of acetabular fractures, I think, the literature sort of doesn't have a good basis for what are we comparing here. And I think that also makes it challenging to have conversations about how to treat these patients.
I love that you brought that up, Aaron. I mean, that's why I love that this paper is included here, right? This is from the Journal of Arthroplasty, sponsored by Akius. It's the ones telling us, should you be doing this, showing us why they think we shouldn't be doing it.
Right.
That's why our panel of people are here who they are. So, Mike or Mike, what do you think?
Well, I think what we really need here is good data so we can build a decision tree model. This is something that hasn't been built. There was this big fad about, was it like 15 or 20 years ago? Like decision tree analysis was like the thing, and you'd figure out like, should I explore the radial nerve or not? And they'd have all these decision trees to see what all the outcomes are. And to me, the real issue is, and I think Mike, you were talking about this earlier, and Aaron too. Like, you want a crystal ball and see what the future is, and we don't have that. And the problem is, if you fix something, and this is something that we've seen here, and they were talking about, over 3 months being delayed. Well, there's a big difference between 3 months and a year. If you have someone that you fix them, and it goes bad for whatever reason, there's some kind of mechanical failure, they get AVN, they get post-traumatic arthritis, whatever. If you reoperate on that patient and do a total hip within a year, your complication rate is sky high. Like, the infection rate is very high in that population. It's almost 10%, which is very different than a regular primary hip population, very different than a fix and replace if you do it all at once, and very different than if you read the papers that say, you're converting someone that had an acetabular fracture to a total hip 5 or 10 or 20 years later. Those infection rates are very low. And so what you really want is like to minimize the overall harm that we're causing or maximize the overall good. And so I think, this paper adds one little piece to that. But again, I try to take the long view with these patients. This isn't like a fracture surgery where we care about a 6-month outcome and it's healed and we know they're going to be fine. We're really looking at the long ball. How's this patient going to do in 5 or 10 years? What's the trajectory of their care? And we want to do one intervention that minimizes any further surgical insult while minimizing the chance of a complication. Certainly, these are high-risk procedures, but that doesn't mean that the alternative is lower risk. Like, if you fix one of these, that's one surgery for sure, and very likely a second with a high complication rate. So I try to put it all together to make these decisions.
I think I think you asked a really good question before, Aaron, as far as what groups do we need to be comparing? And to me, the basic question that I want to ask in my own head, in my own practice, is who's having, honestly, dramatic complications, and not that a dislocation is not a dramatic complication, but to me, that's like not a huge deal if I've got well-placed components. To me, the question mark is who's getting infected early, who's getting infected if I do them right away? And that question you just asked, Mike, those patients at 1 year are at such high risk. And it must have something to do with colonization and these patients having this inflammation that is ongoing after trauma for such a long period of time. We don't understand it, and we have to get to those answers. And we're all of these studies are asking these broad brushstroke questions when we really need to be asking the life-changing questions for patients. And I think that's how we finally get to that almost decision tree type model, like you were mentioning, Mike.
That's a great point. I'm going to ask that we just move on to the next paper just so we can get through the last few. Because I don't want us to get too hung up here in the details.
Yeah, so this is now we're kind of getting into the doing it papers, right? So we've got some background already now when it comes to the incidence of these things and what their short-term complications are, right? And so now this is kind of a paper looking at how people do following this. So this was a Swedish study, a retrospective study comparing patients that had ORIF alone versus a fix and replace strategy. And this is really highlights the problem that we have in this problem. There were 27 patients in this study, which is not very many. And there were 14 that had fixation and 13 that had a fix and replace strategy. So that's not very many to make it into British JBJS, but it did. The primary outcomes were reoperation. In the ORIF group, that was revision to a total hip. And then in the in the fix and replace, that was a revision hip or failure of the components. And then in the patients that were treated with ORIF, that was conversion to a total hip or failure of the fixation in some way. And then their secondary outcomes were physical function, and they used the SF-36, which is something that was commonly used at the time. Now we seem to be more into PROMIS instruments and things, but that gives you a decent idea of pain and physical function. There are multiple domains that are checked. The two groups were pretty different. So the ORIF group was younger. The mean age was 68. Range was 50 to 83, whereas the fix and replace group was almost a decade older at 76 with a mean age of 64 to 89. So right off the bat, now we know these are actually two very different groups, right? Like a decade is a big difference. Again, the numbers are small, and these are a heterogeneous group of fractures. So the ORIF group had 5 posterior-based approaches, 5 Cokers, 8 ilioinguinals, and then a combined approach in 1. So that kind of gives you the sense that these were more anterior-based injuries, anterior columns or anterior column posterior hemitransverses, or both columns. The fix and replace, a little bit different. 11 of those 13 were Koch and Longerbach approaches. So those are, again, more posterior injuries, like transverse posterior walls or posterior walls, with only 2 having an ilioinguinal. And one of the kind of key things in this paper is that all of the fix and replace patients, they were fixed with a cage. So this isn't something that we're talking about doing here. Like the cases that you've seen are all hemispherical ingrowth cups. And this paper is talking about 13 patients that were treated with cages. And but the results were really good. So they had no reoperations within 2 years in the fix and replace group. And then of the ORIF group, 9 needed a conversion. So more than half of the patients that were fixed needed a conversion. Interestingly, while not statistically significant, the ORIF group had less pain and better physical function than the total hip acutely group. And I think that probably plays more into the age difference than anything. 10 years is a big difference. And many of those patients that had ORIF ended up having a total hip anyway. So maybe it worked really well, and that's why their pain was so low and their function was good. Certainly this is one of the papers that was kind of tantalizing and saying, hey, maybe the reoperation rate is lower if you do a fix and replace strategy. Because, we just had this discussion about, are you interested in comparing apples to apples or apples to oranges? And so here we're saying the best treatment that we had before is fixing it. And now let's compare fixing it in the same population to fixing and replacing it. But again, lots of challenges, different patient population, different fractures in that different patient population, way underpowered, right? Like 15 to 14, you can't compare functional outcomes. You can't compare anything unless there's a huge difference. So the difference they found was only there because they had a reoperation rate of over 50% compared to 0%. But certainly it's an option. And just to kind of highlight this with a case, do you mind if can I share my screen?
Yep. I think while you're bringing that up, Mike, I'll just make a comment. I really elegantly said the utilizing a cage for these can really reflect, high level joint replacement skill, and maybe having 9 that go on to total hip so acutely, maybe our skills were more one way than another. And that's kind of one of the difficulties in bringing in a partner who's really skilled in whatever, you may not feel is your best surgery might be the best thing. So go ahead, Mike.
No, certainly, you would expect a, 30% to 40% failure rate at 2 years. And so that is definitely an outlier. This is a cage is not something that we use often in America. And so I just wanted to show you a case because it's certainly not something that I do very often, but once in a blue moon, why not? So this is an 85-year-old patient. They have this anterior column fracture with protrusio. There's comminution of the anterior column, there's protrusio, and then it turns out there is extension through the back. So the posterior column is involved as well. So kind of a challenging patient and a very frail person. So a cage is a decent option for something like this. This is what it looks like. I'm a big templater. I template every single arthroplasty that I do. We should plan our fracture cases, and we should use those same AO principles for an arthroplasty case. So I template and plan all these cases. This is my cage and my plan. Unfortunately, you can't bend it very well on the templating software, but at least you can put it where you think it belongs. And then this is it doing it. Again, I think I'm curious what Mike and Aaron do, but I'm a big fluoro guy when I'm doing an arthroplasty case, particularly for a fracture. I want to know that I got a good reduction, and then I want to know my cup is in a good place, and fluoroscopy really helps me to do that. This is putting the cage into place. It requires a fair amount of contouring. It requires a lot of screws because this is really a mechanical construct that depends on those screws, screws up and down. And then the liner, the acetabular shell, is cemented into that cage after bone grafting behind it. So I bone grafted behind into the defect using the head, and then cemented in a liner. The liner I like has a little metallic ring, so you can kind of see the version and everything of your cup. So this is it. And then this is her at 2 years. She succumbed to her other illnesses a couple of years after this, but this was something that got her up and moving, and it is a little bit different, but is something that allows early weight bearing, and certainly I think is a nice technique occasionally.
Yeah, I absolutely love the use of a cage for some of these, and I think there's a real deficit or need in the marketplace for ingrowth cages that and we're facing a big problem with that right now. So I think that it's really a technique that works for the right patients.
It's exactly what I was going to bring up is, I think the cage is a nice construct to allow you to sort of have a contoured plate that fits inside where the acetabulum used to be, and allows you to get screws above and below your fracture lines. But I think one of the main reasons I don't use it more often is because I worry that longer term, if you don't have ingrowth, that sort of, you don't have anything that's holding that stable. So I think in the shorter term, if you have a low demand, almost palliative type surgery, I think it's great. But in your 58, 60-year-old motorcycle patient, I worry about putting that sort of construct in. But in the really low energy, frail, fall from standing, terrible osteoporotic bone, I think it's a great option.
Yeah, I was taught that a cage will not last more than 5 or 10 years at the absolute maximum. So this is really someone that's got to be frail, octogenarian, like this is a short term. And that's what worries me about some of these other studies is they're putting cages in 50-year-olds. Like that to me is a little bit crazy.
Yeah, when those fail,
Yeah.
they're not fun.
They're a gift for life. So our lives.
That's what's, I think, like a little bit of a thing with this that is a little bit of a different perspective in the fracture world. If you hit 2 years follow-up, that's high fives. That's the highest quality follow-up that you can ever achieve is 2 years. 2 years is the entry level for arthroplasty follow-up, right? And so, I think it requires a little bit of a different mindset when you're looking at these studies and thinking about it.
100%.
Right.
we
And
can,
we have about 5-6 minutes to try to get through the last case, and that'll leave us some time for some final Q&A as well.
All right, I'll go real fast on this one because this is another paper that is really challenging because it's very low quality, which is just a reason for you guys to do a bunch of research and help us understand this better. So this was a prospective observational study over 6 years, 54 patients. Those 54 patients represented a group of patients treated with fix and replace out of 266 total patients. So what is that? 1 in 5 roughly of their patients were treated with a fix and replace strategy. 2-year follow-up, primary outcome was Harris hip score, but they also looked at reoperation and mortality. The mean age was 54. So again, this is kind of a different patient population than we're talking about. Like, we're not talking a mean of 54. 54 would be on the low end, I would say, on an age that I would consider a hip replacement. Certainly, there are patients that are younger than that would get it, but it would take a very bad fracture. All were fixed and replaced. Now we're talking about patients that were treated in a strategy that I think the 3 or 4 of us would advocate for, which is using a hemispherical porous cup, obtaining good columnar fixation. So it's important to restore the columns and bridge that with a plate to create a tension band. A press fit of 2 millimeters, and then multiple screws. I think it's interesting that they called out they like to use only 2 screws. Personally, I use every single screw that's in the cup if I can. And if I have to make more holes, that only makes me happier. So I use the metal cutting burr and add more. But more screws is more. They only had 5 cages, so like a few cages, but I think that's appropriate. You know, like once in a blue moon, there may be a case that needs it. What was really interesting is their outcomes, at least as far as cup longevity, were very good. And this is something that's been echoed in a few other papers. I guess if there were 54 or 5 cages, there were 49 patients that were treated with an ingrowth cup. Only 2 of those needed a revision. So that's not too bad. That's pretty good. So there was 2 revisions for a loose cup, 1 dislocation that required a closed reduction. There was a typo. And then a few cases of mild HO that didn't require excision. So overall, that's a pretty good outcome profile for the procedure. 2 revisions, and then a few complications that could be managed conservatively. And then as far as Harris hip scores, their patients did reasonably well. 37 patients had what would be considered an excellent result according to the Harris hip score. 17 had good results, whereas only 5% of patients had poor outcomes. So overall, pretty good functional results, and I think pretty good outcomes as far as longevity of the components, particularly the only 2 revisions for a cup out of 49 is not too bad. And so I think this is one of the larger studies that looks and fix and replaces, but there are a couple smaller ones that have either no revisions for the cup or low revision. So I think the strategy outlined here, which is restore the columns, restore the anatomy, achieve a press fit, and use lots of screws, which is kind of our kind of contemporary strategy here in the States, works pretty well.
I thought this paper was interesting for a lot of reasons, and the first one being their great results, really across the board. And although it was an enormous study, this is I believe the study was in Karachi, and it's really, this is a worldwide problem. This is a worldwide issue that we need to solve, and it's not going to be solved tonight, but hopefully this gets us all thinking about this, because these cases do exist. And it's, to me, I'll just go through this last case here as we wrap up for the evening. But this was a 70-year-old gentleman. A tree actually fell on him while he was at Sandals in the Caribbean, and he was more than a week out with this particular injury. And I think Mike and Aaron, what are your thoughts on this particular injury in a 70-year-old, otherwise totally functional man who works full-time doing construction?
I think you have some containment medially that you need to address. And there's some dome impaction. And I think for me, I think he's the right age group. It's the right fracture pattern that's sort of challenging to fix and would benefit from acute fix and replace and all of the associated things that go with that, right? Earlier mobility, earlier back to doing what he wants to be doing.
Yeah, I would agree.
Yeah,
I think the dome impaction is something, even if you get that down, it doesn't last.
Yeah, I think that was kind of my thought. And, Mike, you brought this up earlier about just thinking about how to do these things, just some more images of the actual injury. And the treatment algorithm for me that I was using here was he was very delayed to the OR. He's osteoporotic. He's 70. He actually had a diagnosis of osteoporosis, which is rare in a male, but extensive impaction. I felt that this was a large part of the dome, likely suboptimal reduction in this one. And even if I got it reduced, really getting that piece as a free floating piece, the survival of that dome piece, I think is very challenging. And this is a totally functional patient. So these are the things that went into it for me. And luckily it was an anterior fracture pattern. So we could do the supine with a typical Fannin steel with spacer retzius and work on that fracture where we wanted to on I utilize a specialty table, but you could do this any way that you want. Inline traction. And this brings up something I brought up before, and trying to get through these things expeditiously and not paying so much attention to the joint in this setting. I always kind of set the clock at an hour and a half towards being done with the ORAF portion of this. I don't know, Mike or Aaron, if you have a specific kind of time point in mind here, but I thought that
Anesthesia is done putting lines in by an hour and a half. I'm happy.
So true. So then we buttress everything, but you notice that the joint is not even close. I mean, that's something that I'm purposefully doing. And
But you've
one
got
thing
the
that I
hip
do
center
is
back down, right? And I think that's a nice thing that you can use when you're on the traction table, and when you're supine using fluoro. It's nice to see where you can have both hips, and you make sure you got the hip center in the right spot. And that's something that when I'm doing these in the lateral position, it's harder to accurately assess.
totally agree. And sometimes it's hard to keep the head out of the way when you're in the lateral position. Very challenging. And for me, I use this point in time to stop, and I typically will have them send an ABG because I feel like we're still in this mode of, I don't want to say experimental, but we're still discovering how well we can do these, and we want to keep these patients safe. So I want all these pieces of information and talk to anesthesia and just keep it moving. But definitely don't want to hurt them and want to keep that to under 3 hours. And so doing the total hip in the typical position, but allowing ourselves the opportunity to do this using fluoral, like Mike said, impacting graft, so reverse reaming that femoral head into that defect, and then utilizing a rim fit, like Aaron, like you said before, and getting that rim fit and avoiding not having that fixation, and then getting us to a right place. And when I'm thinking about this in an algorithm of care here, and these patients are what we're trying to get back to, and this is a different patient, but same exact kind of concept about how do we get her back. And we'll notice that it's not perfect total hip. It's got more offset. It's got a different look than a primary total hip would be. But in the end, this was what meant everything to me. This patient, doing well at a couple of weeks post-op really kind of changed her outcome. And that's, I think, what we should be thinking about as we go forward here. So just in conclusion, these are the things that I took away here tonight. So lots being written about acute ORF and total hip. We see that across the world. People are thinking about this, and we're going to have to get to some answers. And maybe there is more of a concentration on disasterplasty and what we should be doing. And ORF, if viable, if it's reconstructable, it should always be our probable first look at this. And then non-op of an otherwise unstable fracture should kind of be driven by morbidities of the patient, not avoiding surgeries that we should be doing. Aaron, Mike, you have any other thoughts?
I totally agree. I especially on that last point, it's the comorbidities of the patient are not necessarily driving whether I'm doing total hip or ORIF. It's more, is this patient safe enough to have the surgery? And I think we're sort of, I know at least at our institution, we're not really applying those elective arthroplasty criteria to these patients. We're looking at the patient as a whole. What do we think we understand about the fracture characteristics that would benefit, that the patient would benefit from a total hip up front, and not necessarily excluding them for things that they may get excluded from an elective arthroplasty for.
No,
Great.
absolutely. I would just say, I think this is something to jump into. but do it carefully. And I think if you're interested in this, then certainly there are a lot of people across the country that would love to talk to you and kind of figure out strategies. Start with a posterior wall, for example. That's the place to start with this, and then build up from there. But certainly this is a great technique. And if you are a little bit queasy about it, then have a partner do it with you, because I think having an arthroplasty colleague do it with you is a great way of getting through it.
I totally agree. If you're more comfortable doing one of the two portions of this surgery, have a friend that's more comfortable doing the other portion, scrub in and do them with you, right? I mean, these are absolutely things that two brains are better than one sometimes.
That was awesome. I have a few questions here from the chat. If people can just kind of quickly give their thoughts. Do you position your cup any differently in these types of cases? Maybe more anteversion on the cage or the cup, or maybe use new porous options like readapt cups with multiple locking screws. Any thoughts on those concepts?
I think Mike touched on this, right? Like if you've got something that's posteriorly unstable, then that's what you've got to worry about. So, like certainly no one would argue with 40-20 for every single cup, but if you end up 40-30, that's going to be totally fine. So a little bit of extra anteversion probably didn't hurt. And then, the data for this is a little limited. There's only one paper that I've seen, but dual mobility, some kind of like additional bearing surface may have a role in reducing the risk of dislocations. And so that's something to think about, although certainly there's not an exact answer there.
For me, I'm trying to get the hip center where it's supposed to be and make sure we're not elevating it too much, recreating their offset, getting the muscle tension right. One of the questions that we talk about in primary arthroplasty a lot is the spinal pelvic relationship. And for me, in these patients in particular, I don't have a good sense always of what their spinal pelvic do they have a rigid spinal pelvic? Are they stuck sitting? Are they stuck standing? Because in my elective patients, I'm dialing in the cup position in terms of how much version I'm putting on, more related to spinal pelvic. And you don't have a good sense of that with these patients. So, I would just caution you with over anteverting everybody, because in the wrong patient with the wrong spinal pelvic alignment, if you over antevert them, you may actually predispose them to coming out the cups or coming out the front. And I think it's complicated. And I think that's just why it's, there's a minimum that gets back at that minimum number we were talking about earlier, right? You just got to be comfortable doing enough cups so that you're comfortable putting it in, or have somebody who puts in a fair number of cups there to help you.
Yeah, I totally agree.
Perfect. A quick one here. So we've heard a few comments about earlier mobilization with fix and replace. Everyone letting them weight bear straight away, or is anybody limiting them?
Like that's an interesting question that I ask myself all the time. For myself, if I've got a pure wall that I'm doing this on, I will typically let them weight bear right away, because I'm going to fix the wall. I'm going to buttress that. That's going to be really rigid, and then I'm going to get great screw fixation in my cup, and I feel that that's adequate. When I've got column and wall, I will typically make them 25 pounds weight bearing until I'm confident that their fracture's healed at 6 weeks, and then I'll allow them to move forward. I don't know if that's right or wrong. I have no idea, but
I think I do similar. It's I'd say the size of the defect and how much I'm bone grafting probably drives it. So if I'm sort of bridging columns and there's a huge defect, then I'm shoving their femoral head and another femoral head in that defect with impaction grafting, I'm less likely to weight bear them. Whereas if I have a younger person with good bone quality and just a wall, I'll probably weight bear them right away.
Awesome. And there's one final question here, more a technical question. How are you gaining enough lateral and posterior exposure through an AIP on a HANA? This person's commenting they typically do it free leg with the leg over a triangle to relax the anterior structures. But maybe if you could discuss maybe the technical aspect of how you get your exposure with the leg under tension on a HANA.
yeah. So I think the question is, how do you get that hip flexion reliably? And you can actually get it pretty reliably just by using, there's a leg elevator that you can put behind the calf, and then you can slide the traction up. people do that all sorts of different ways, but even just sliding the traction up a little bit and locking it in, they'll give about 10, 15 degrees. And usually I really haven't had a challenge in getting that exposure.
How about Aaron or Mike Weaver? Are you guys using the Hannah or are you doing it free table?
So most of my practice is posterior hips. I did a lot of anteriors in training, but I would say predominantly when I'm doing sort of regardless of where we're plating, I will put the hip replacement in from a posterior approach. So we may do an AIP, put the anterior column plate on, get even if it's one of the pre-contoured plates, getting some containment of the quadrilateral surface, and then we'll go lateral. To your point earlier about having anesthesia send some labs, I find that that's sort of a nice stopping point also, because in the amount of time that you need to take to close, reposition the patient, it will, if the patient is going to start crumping, they'll display signs of crumping at that time. And, it's a nice stopping point. You can always come back later. And then if we can do everything from the back, we'll do it all from the back.
Yeah, I'm similar. I'll reposition. I do a fair number of anterior hips for arthritis, but not, pretty rarely for this.
Awesome. Well, we have just a few minutes here. If there are any other points that any of the panelists want to bring up, we've gotten through all the questions that came through from the attendees. So thank you for bearing with us with that. But this was really informative. I think this is exactly what we wanted, right? We wanted to start the discussion and get people thinking about this stuff.
Thank you for organizing this, and thanks to the AO for hosting.
Yeah, so in the
Yeah,
last
fair
2 minutes, we'll just run through. These are some of the upcoming events coming through for AO. If you're interested in any of them, make sure you write down the dates. Lots of good resources from AO, so feel free to take advantage of all those as you move forward, and feel free to contact any of the panelists if you have any questions about your practice. But thank you guys for joining us tonight, and I hope everyone got a little bit out of this. I know I certainly did.